A very good morning to everybody. I believe it's quite cold in Delhi and in most other places. But thank you all for being here with us for this very first session of Let's Talk. As a member of the Advocacy Committee, today I have the privilege to welcome all of you. I am Kirtida Oza, and I would like to extend a very warm welcome on this cold morning to everyone. We thought it would be a good idea to begin a series of sessions where we get to know each other. We are all part of the ORDI PhD community, but there isn't enough interaction between us all the time, and therefore we hardly know what each other's groups are involved in doing. And there's so much that we can learn from each other. So, with that in mind, we thought this would be a wonderful initiative where every week or so we could invite two PHE members to take us on a tour of their journey and help us understand what they are working for, what their challenges are, and what their goals are for their work ahead. So today we have with us two very dynamic leaders. We have Ambrish ji and we have just a minute. I seem to have forgotten the other
Rahul?
name. Can
Rahul
somebody?
ji. Rahul ji.
Rahul ji, yes, yes. This happens because I tend to get brain fog as part of my own illness. And I'm sure all of you understand what that is. Sometimes names just slip out of one's mind. But I am very happy to welcome Rahul ji from TSC Alliance and Ambrish ji from Parent Project Muscular Dystrophy. And without taking much of their time, may I request Rahul ji to begin telling us more about his journey? Thank you very much.
Thank you. Thank you for inviting me to share my experiences. I'm not sure all of you are such experienced in running organizations, how much benefit I can contribute. However, there is a particular path our organization took, and I'm very happy to share how we are going about it. One thing I must, let me just go a little bit into the history of how this organization was born. It was very organically evolved, like somebody from US had started a Google mailing list way back in 2015. And around 2017, there were about like 10 parents on that group, and mainly the kind of exchanges were on like how to manage TSC as a disease at home, not talk too much about treatments or research, but what are the day-to-day challenges, and just like some shoulder to share your frustrations. And slowly that mailing list morphed into a WhatsApp group. So around 2017, we had about 100 people, 100 parents on that WhatsApp group. And it was quite active, like almost everything that affects a parent was discussed in that WhatsApp group. It was providing support also. So for example, if the child has an emergency, the parents were immediately able to take the child to the ER, or don't worry, it's got nothing to do with TS. It's normal. So there is a very strong bias towards like a community, So the thing is, what we share amongst ourselves is very personal, and we don't want that to be, what do you say, read by outsiders. even medical professionals, we very consciously kept out of the WhatsApp group. And that was pretty much the genesis of the organization, saying that, listen, we as parents or caregivers need more support in terms of fighting for our rights or advocacy, or like getting the best clinical practices into the country. And that was when this organization was formed, So this organization official birth was in February 2018, but it was launched to the world in the ICNA conference in November. And the kind of leadership we had or have still have is all professionals, very professionals, IT professionals, management professionals. And from first, we were very clear as to like what the objective should be and the mission of this particular organization should be. There was no really mission drift in the sense like we will get into financial planning or financial services or financial handouts, or we will fund research projects. So there were very clear boundaries and guidelines. It was meant for the community and by the community. It's first and foremost empower the community. So that was basically one of our values. And once we formed our organization, we formed a partnership. We are part of this global alliance of TSC Alliance USA. Now, TSC Alliance USA has been around for about 40 odd years. It was again started by a bunch of parents, mothers, and they have taken it forward. And they share similar values, in the sense like it is for the community, it is not for the pharma sector or for promoting the doctors' agendas or anything like that. It is first and foremost for the parents and the caregivers. Now, the good thing about this being part of this alliance is like there were 8 organizations, and the purpose of this alliance for the US organization was to mentor and guide the young organizations. We were hardly like months old when they took us into their wing, and they provided us with all the necessary tools, support, documentation, and even manpower support as far as like structuring our plans, how to go about it. And they never mandated saying that you have to do this, but they always said like, okay, what do you want to achieve? We'll help you with that whole planning process. So that is one good thing which happened to us, in the sense like we didn't have to reinvent the wheel as far as like the management of TSC is concerned from a parent's perspective. They've seen everything for 40 years, and they've just were very open, and they've transmitted the knowledge downstream. And the second step we felt was to build credibility for our organizations, in the sense like we cannot do this only as parents. We need to integrate with the medical community, doctors at some level, seeing that this organization is going to be an extension for the treatment which they plan out. In the sense like the doctor cannot be sitting on the patient all the time. Majority of the care happens at home. So how does the doctor and the organization and the parents, they work together in giving like 24/7 support to the patient is one of the things which came up. And for that, nobody really took us very seriously initially, but that's when we felt like that's when we felt like we need to build our brand and credibility. And we took the help of TS Alliance USA, and we organized series of workshops in premier institutes, both for the parents as well as the doctors. Now, the people we brought over from US are the number one researchers in TSC, both from the clinical perspective as well as from the behavioral, the non-clinical side, which is.
Rahulji, may I interrupt you for a minute?
Yeah.
May I request you to, just for the benefit of all of us who do not know about the disease, can you just tell us a very briefly about what it is and what is this TSC Alliance?
Okay, sure. TSC is basically like there are defects in two genes, which is TSC1 and TSC2. And what this does is it dysregulates the cell growth. And because of it, tumors form randomly over on the body. And if it forms over vital organs like a brain or a lung or kidneys, then it becomes problematic. One, there is no cure for TSC, and the treatment is symptomatic. And symptoms, majority face seizures. They have epilepsy, and that goes through the normal treatment cycle of epilepsy. Then we have lung issues, and they have like very strong medicines for that. They're called mTOR inhibitors. And cysts and what do you call tubers form on kidneys also. Those are dangerous. So again, there are ways of treatment for that. So basically, there is no cure. Wherever a particular organ is misbehaving because of the existence of a tumor there, we have to treat it symptomatically.
So does it affect children at birth, or is it a disease which comes on later?
It is at birth, in the sense like it is passed on by the parents. Or, I mean, if the parent has it, there is a 50% chance the child gets it. Otherwise, majority of them are random mutations in this. So currently, the diagnostics are pretty good. So they are catching it in the womb itself. They're catching the disease in the womb itself, or immediately after it's, if there are showing any symptoms like skin conditions or tumors in the heart, they are capturing it. But most of the diagnosis of like average to severe cases, by 4 months, they are able to start the treatment.
Okay. Thank you very much. So please continue with what you were telling us.
So this TS Alliance is basically is like a patients organization. They're based out of US, and they've been around for 40 years. They've accumulated a lot of experience. They have accumulated a lot of experience in advocacy, fundraising. They have like $100 million budget. So they do a budget in the sense they control that kind of funds. So they get a lot of sponsorships from Department of Defense, Pharma, and they channel it to the research organizations like universities or pharma companies. They do sponsor a lot of clinical trials. So they're doing a lot to find a cure also. So that gives us an advantage that somebody is actually actively looking at how to cure the disease rather than just manage it. And so coming back to where I left off, we were able to build top-notch, bring top-notch researchers into the country. We had them interact with good, the leading doctors in India. So we had like a parents workshop and a CME, professionals workshop at AIMS Delhi, Kokulaben Ambani Hospital in Mumbai, and KIMS Hospital in Hyderabad. So what this did was the doctors were able to interact with these leading professionals from US, and they learned a lot, and vice versa. The Indian doctors and researchers also presented a lot of case studies. They had discussion on the case studies. So what this did was like it formed a nice little bond between the Indian doctors and the US doctors. So, and as an organization, we kind of encourage that interaction. You know, once in a while, we sent out newsletters from US to the Indian doctors, and vice versa. If there is any Indian doctors who needs to contribute a case study, we forward it to the appropriate universities in US. So we are kind of encouraging this kind of transfer of knowledge between the leading researchers in US and Europe and India. Now, collaboration. One thing, because we are a very young organization, we don't have too much of experience in advocacy. And right now we feel like there are organizations like ORDI, Rare Disease International, which do advocacy much better than what we could do. So we take the help of, we have joined ORDI network, and any issues I have with advocacy, I put it up to Mr. Prasanna, and he makes a strategy for us, saying, let's do this together, or you do this, you use your parents to uh, put pressure on the government, write letters. He's even offered legal services to draft letters. So that way, that relationship is working out very well, you know, because the thing is like we want to concentrate more on the disease, not on the advocacy part. Advocacy, DSC being a rare disease, we don't have the numbers, and I think all of us put together, the numbers will add up, and somebody will listen if we make enough noise. So that is our approach to our partner organization. We would share our expertise, and we would borrow their expertise, and we don't want to pretty much reinvent the wheel. And we want to do a lot of, we want to promote a lot of research activities, not research activities, by encouraging young medical students or people who are doing research in medical institutions to take a look at TSC and do something about it, like investigate something within the Indian context, because all the literature that is available is like US or Europe. There is nothing about India. So we've kind of proposed a very big project to create a natural history database for TSC patients, and that should be getting started shortly. And the way our goals and missions, if I can be allowed to share my screen, I'll just
You can share, sir.
yeah, going. So we've used the theory of change framework to kind of build up our what we should be doing. And at a very rough level, we list out all the assumptions, what we want get done. We look at all the constraints which we have, in the sense like we don't have enough volunteers, we don't have enough staff, we don't have enough money. We need to build a relationship with the medical institutions, partner organizations, and also knowledge we still need to download. And out of that, we said, like, based on all these assumptions and constraints, we need to build a community, a very strong vocal community. We need to build a learning platform. We need to have like a knowledge base of articles and research papers. And we need to have the necessary tools like a TSE registry or mobile apps or sharing apps like WhatsApp. And these are the outcomes we kind of said like we will concentrate on. So from that whole planning process, our mission statement was evolved. And very clearly you can see that our focus is still on the community, and we would be, what do you call, I mean, our belief is like if the community is strong and if the community has the knowledge, it will make the informed choices, because there are a lot of misconceptions as far as treatments and concerned. So we want to avoid that, and we want to make sure the patient gets the best care. So part of the goal is for us to build a community and empower the community, advocacy of best clinical practices towards the medical institutions, improve access to healthcare. Because a lot of people, I'm pretty sure it's the same with other diseases. This is a multi-organ disease. So what happens is, and the treatment is symptomatic. If there is TSC, does not have a disease. So if somebody is having seizures, they will go see a neurologist. And the neurologist, even if they are aware that it's TSC, they will not refer them to a kidney specialist or a lung specialist, or get the other organs also checked out. They'll deal with their part and they're done with it. So when we say improve access to healthcare, we have like surveillance guidelines, diagnostic guidelines, which we've got from Europe and US, and that we are asking the doctors to follow them, and we are also educating the parents to insist on the doctors to follow them. So every year, there is a set of like about basic minimum of tests that needs to be done to make sure no tuber is growing anywhere, or if there is already an existing tuber, is it growing, is it shrinking, do we need some aggressive treatments? So that kind of follow-up can happen. You don't have to wait for something bad to happen, and until then something bad happens. Also, we are very, what do you call, particular about governing the TS Alliance in a professional manner. So we want to have very good governance standards. We want to have very good people working with us. And for that, we have a very strong board, and we are building up an advisory group so that any initiatives we take an advisory group consists of like people from various aspects like parents, fellow NGOs, doctors, uh, advocacy, policy makers. So we have all of them together. And if we say like we want to do a TSC registry, and that's a big initiative, uh, they will be able to guide us as to what is the best way to get it implemented, what are the pitfalls, what are the legal hurdles you'll face, so all that stuff. So we have a very good advisory board also built up. Just as an example, each of these goals, we have made it crystal clear, for anybody taking ownership of that particular goal, like I said, management. So some of the strategies are, I'll just take one as an example. Make it easy to find the TS Alliance. So for example, if a particular doctor diagnoses a patient as a TSC patient, they should be able to understand, the doctor or the parent should be able to find TS Alliance and figure out how a TS Alliance can help them in the journey of managing of TS. And even onboarding process should be very seamless. It could be just a phone call or a WhatsApp message. And then we have like support groups. I mean, right now virtual because of COVID, we've not been able to build physical groups. But there are groups available in all the major cities and major languages, so that if some Bengali patient comes and they're not very well versed, they can speak to their group in their own local languages, and even the group knows what are the strengths and weaknesses of the medical support which is available in like West Bengal or something like that.
Rahulji, may I request you to quickly wind up because
Yeah,
we
just last
still
3
like to
slides.
have. Yeah, okay, please.
So for each of
Just
these
quickly go through
yeah.
them, please.
So for each of these slides, sorry, the goals, we have the activities listed, so we can elaborate on it. So for example, develop a website with membership, listing the membership benefits, very clearly written, and even the outputs. Once you perform the output, what is the thing which comes out of the whole thing, like say for example, when your doctors are contacting you, we are constantly building up our CRM database of individuals, medical professionals, and we are part of the outputs also. We are building up the first time information packets in English and all native languages, so that a parent who encounters this disease first time, they are what do you call, not left in dark, or not, they're not like misled by rumors and false treatments. And we have indicators as far as each of these goals is concerned, whether we are meeting the goal or not. So this is basically how we planned out. This is our strategic plan, and we believe in delegation. So all these goals are delegated to everyone, and everybody knows what the other person is doing. So because the plan is open, and they can work independently. A lot of these activities, for example, when you say TSC individual onboarding, like I said, it could be through WhatsApp, it could be through a phone call, it could be through a web form on a website. It is left to that individual person to figure out what is best for their region. So this is what we are doing. So that is where we are. So I see a lot of questions. I'll answer them one by one in the chat box.
Swami, please mute others who are, there is a noise. And also, Kirtitaji, one sec. I take the opportunity to welcome Dr. Rashid Merchant, who has joined us. Probably he will say a few words at the end of the other session. Good morning, sir. Welcome.
Good morning. I'll unmute myself.
Yes, sure, sir.
Thank you so much.
Yeah, please go ahead, Kirtitaji. Kirtitaji, you're on mute.
Yeah, we can't hear you.
Should we continue with the session, or should we hear
Yeah,
from?
we'll continue the session. At the end of this session, probably we'll add a few words.
Okay, then thank you, Rahulji, for an informative talk on what you do and what the disease is all about. We will take questions if we have time towards the end. Otherwise, you can please respond in the chat box. Can we have Amrishji tell us more about the parent project?
Yeah, sure.
And also a little brief about the disease itself before you begin.
Of course.
Amrishji, over to you.
Thank you. Thank you. So thank you, Prasannaji and the ORDI team for giving me this opportunity to talk about our organization and about the disease in general. Now, first of all, let me just brief you about what is muscular dystrophy and what are the types of muscular dystrophies. So basically, the muscular dystrophy is the muscle wasting disorder, and it's a genetic disorder. The most severest type of muscular dystrophy is Duchenne, and the mild one is Becker, and then there are a lot of other types of muscular dystrophies which fall in the category of LGMD, the limb girdle muscular dystrophy, where there are almost 27 to 30 types of muscular dystrophies. Now, our organization is mainly concentrated on Duchenne muscular dystrophy and Becker muscular dystrophy, which are the childhood muscular dystrophies. Now, Duchenne muscular dystrophy and any other muscular dystrophies are a form of genetic disorders, and it happens because of the mutation in the dystrophin gene, which is one of the largest in the entire genome of the human genome. and most prone to mutations. Either this can be inherited from the parents, mostly from the mother side, because it's a X-linked recessive disorder, and the dystrophin gene is on the chromosome XP21. So usually the child that is afflicted with this disease is the male child, because he inherits one copy of the X chromosome from the mother, and from the father's side he will get the Y chromosome. But because the disease is X-linked, the probabilities of child being afflicted is like 50-50. If a mother is a asymptomatic carrier and she passes on, and if the disease is, if that particular X chromosome with the mutated dystrophin gene is passed on to the child, and if the fetus is a male fetus, then he will be afflicted with the disease. But on the other hand, if the fetus is a female, then she will be an asymptomatic carrier. Now, what is the role of dystrophin in our human body? It has a very significant role, like any other genetic protein. This is also a polypeptide chain of amino acids, and once the messenger RNA is released into the cytosol, it gets spliced, and during that splicing process also there can be some mutations which can abruptly come up, and in that case it happens that the mother and father both are, the father is anyway not affected and the mother is also not a carrier, but in some circumstances where the mutations are very random and specific, the child can develop a muscular dystrophy. So the role of dystrophin is like a shock absorber. It will connect the intracellular, the cytosol, with the extracellular matrix, and prevent the muscles from any kind of force-induced injuries and contraction-related tension that is there on the muscle. This particular protein will try to absorb that, along with the other proteins which are forming the dystrophin glycoprotein complex. Now, in a normal circumstances and normal people, like when we do our movements, when we do our exercises, we generally don't lose our muscles because we have a robust system where regeneration system is there, where the satellite cells will again regenerate the muscles that are wasted because of exercise and other movements that we do in our normal work. But in Duchenne muscular dystrophy, the regeneration is something which is compromised. The satellite cells which will regenerate the muscle fibers, are also having the same genetic mutation. And so even though the muscles will regenerate or repair, the repair work is pretty much substandard. And the new muscles which are formed are also with the same genetic mutation. So eventually when the satellite cells run out of stock, there where the disease starts to accelerate in the progression. So as I briefed that this is a muscle-related disorder and muscle wasting disease, the symptoms that we find is when the child is born, he is pretty much normal, because at that time the muscles are also all intact. But as he grows, the first muscles that are afflicted are the gastrocnemius muscles, the calf muscles. And eventually he will form a hypertrophy near the calf area, which is not because the muscle is building up there, but it is because of the fibrosis and the inflammatory cells that are accumulating and replacing the muscles, because there is no effective regeneration that is going on. So the first symptoms are the child will have difficulty in getting up from the floor. And that's a typical sign called the Gover's Goas sign, where the child takes support of his own knees or sometimes any other furniture around to get up from the floor. So these are first symptoms and signs that there is something wrong with the muscles. Slowly, as the disease progresses, the other muscles of the hips, the glutes, and the quadriceps in the thighs, iliopsoas, and they also get replaced with the fibrosis. And eventually the child loses the ability to walk independently and is dependent on a wheelchair. So this happens by the age around 10 years, 11 years. Most of the children are wheelchair bound. And as the age progresses, as the muscles are wasted more and more, and the disease progresses, the muscles in the trunk area, the proximal muscles near the spine, are also wasted, and the spine usually bends either in a C shape or in a U shape, forming lordosis or scoliosis. So, and then again, the biceps, triceps are also affected. So the movement of the upper limbs also become difficult, and eventually the child becomes bedridden. And later on, in the terminal stage of the disease, these children will require a lot of assistance. And like our heart is also a muscle, our diaphragm is also a muscle. So they will also have breathing difficulties, and eventually they will require BiPAP or CPAP or a 24/7 ventilator. And some aggressive treatments for the heart are also required, like a pacemaker or defibrillators, to avoid premature heart attacks and cardiac arrest. So this is basically how the disease progresses from childhood to adolescent, and most of the children succumb to the disease by the time they reach their 20s. But with the modern medicines now available, and with all the other this support system is available, from like ventilators and pacemakers, the life expectancy can be increased to around 30, 35. But most of the quality life is not there. It's bedridden after 18 or 20 years of age. So this is all about the disease. And like now I'll just go through our slides. Our organization is Parent Project Muscular Dystrophy, abbreviated as PPMD, and our office is in Mumbai. We are registered with the Charity Commissioner in Mumbai. That's our website, www.ppmdindia.org. Mr. Swami, can we have the next slide? Can we have the yeah. Now these are the trustees of our organization. It was founded by Mr. Jiten Buddhadev in 2008, or I think in 2009. This was the time when my son was just diagnosed at age of 18 months. And probably he was the youngest to be diagnosed in India. And now the children are getting diagnosed at age of 15 months or 16 months and just before 2 years. But 14 years ago, when my son was diagnosed, it was pretty rare to have been diagnosed at the age of 18 months. Most of the children would get diagnosed at 5 or 6 years of age. So Jiten Buddhadev is one of our trustees, and he's a father of late Siddharth. We lost him just a year ago in Feb 2021. And then few other parents also joined the organization on the invite of Mr. Jiten Buddev, Faizan Guritra, Anand Shah, and myself. And this is how we are together since last many years now, and become like a family. Can we have the next slide? Now, this is just a brief about history and the objectives of our organization. Founded in 2009 by Jiten Buddev, Siddharth's father, and his brothers. The objectives of the trust, initially when the trust was formed 14 years ago and registered with the Charity Commissioner, the main purpose of having a trust was to bring all the DMD patients under one roof and spread the awareness about the disease, getting them to the right doctors like pediatricians, neurologists, geneticists, and physiotherapists. Mr. Jiten was connected with PPMD USA, and they were doing a pretty strong work in US, and they remain to be one of the lead organizations in US, led by Pat Furlong, who lost her two sons because of Duchenne muscular dystrophy, and she started the organization in US. And there was a lot of knowledge sharing between her and Jiten, and that is how he started this organization in India after his son's diagnosis. So a lot of knowledge was borrowed from PPMD US, and which was disseminated here, and the patients were made aware about the disease, how to manage the disease, and which doctors they should be approaching. Basically, we have an entire team of medicos who would provide a holistic management to DMD. It's just not just restricted to the neurologists and the pediatricians, but you need geneticists, you need physiotherapists, you need cardiologist and a pulmonologist also, because it's a disease which affects the entire muscular system in your body. Can we have the next slides? Yeah. So earlier we didn't had this WhatsApp, and but we were very much active on the Facebook. So we had a lot of friends interacting on the Facebook groups, and later on when the WhatsApp came in, sort of WhatsApp took over the Facebook, and now we have on the group maybe around 250 families throughout India. So encouraging new DMD patients to join the support groups on WhatsApp to detox their stress. So the new families who join in can ask any type of questions that they have about the disease, and all the other parents would support them, give them the right direction as what needs to be done under the circumstances. Explaining them about the importance of genetic counseling, especially for the female siblings and relatives of the DMD boy's mother. Now, as I said, that as this disease is an X-linked disease, it's very important to counsel the families, so that genetic counseling becomes very important. So to prevent further birth of the DMD child in the family. So we need to first find out if the mother is a carrier, and if she is a carrier, then her sisters or female relatives on the mother's side also should be counseled before they plan for the family, so that at least new births can be prevented. Discouraging them to try unapproved therapies like stem cells being practiced by many charlatans within and outside India. Now, stem cells are, you can find that there are a lot of advertisements done about stem cells, that stem cell is a magic wand and it can cure a lot of disease. And many of our patients we have seen falling prey to such practitioners who who in the name of stem cells are, sometimes not even giving stem cells, but there have been cases where the fraudsters have been just giving saline water, and they have been caught and punished as per the law. So we try to discourage the patients that they should not be carried away by any emotions and get into such kind of traps and experiment the therapies which are still not approved, especially the stem cells which are easily available. Now, helping them to connect with the right panel of medicos who could provide holistic management to the child right from the beginning, so that the life expectancy and quality can be extended and improved. So just not being a neuromuscular disease, and it affects the entire muscular system in the body. It requires a lot of doctors to be involved, not just the pediatricians, but you need to consult a lot of other specialties. As I said earlier, that our heart and the diaphragm are also the muscles. So we need to consult the pediatric cardiologist and pulmonologist right from the beginning. So a holistic management can be provided to the DMD child, and early interventions can be provided apart from steroids. I mean, the job of the neurologist would be that they would just prescribe for the steroids, but steroids have their own side effects. So those also need to be managed. Presently, we don't have any medicines that can treat Duchenne. So we have to just manage it in the best possible manner. And the first medicine that comes to mind is steroids as an anti-inflammatory drug, but it has its own side effect. And steroids are practiced in Duchenne since last almost 20, 30 years.
Amrish, may I please interrupt?
Yeah.
My request to you is to, can you quickly?
Okay. No problem. So can
we
we move on to the next?
Few minutes for questions if there are any burning questions.
Right. So, okay. So objectives of our organization is, nevertheless, we also raise funds through intramural and extramural sources to support indigenous research. This is very important because we have seen that the research that is going on in the US and Europe, and ultimately the outcome of that research is the drugs which are recently approved by the US FDA, but those drugs are humongous. I mean, they're exponentially expensive and beyond the reach of average Indian families. I mean, the very recent example I can give you is about the gene therapy drug that was approved by US FDA for spinal muscular atrophy, which is costing now 16 CR. And many of you must be knowing that the SMA community is struggling to get funding for this drug from the our main goal, our main charter in our organization's objectives is to fund research within India so that we can have the drugs available at the price where the average Indian families can afford. So this is what we are aggressively doing, putting in efforts to try and develop drugs within India so these are available at the affordable prices for the average Indian families. Can we have the next slide? The research projects that are being funded and assisted by our organization. The first one is the recombinant AAV gene therapy ligated with the micro and mini dystrophin.
I'm sorry, Amrishi, you have unmuted you have muted yourself. No, it's still mute. Yeah.
Now?
Yes,
okay.
now we can hear you.
Okay, sorry. So the research projects that are funded by our organization is the first one being the gene therapy, which is the microdystrophin and the mini-dystrophin gene in collaboration with Narayan Netralaya, Bangalore. And we came in touch with Dr. Ghosh in 2015. So it's a pretty long time since we were negotiating with him as how to move ahead with the research. And after a lot of deliberations, ultimately we signed the MOU with them in Feb 2019. The current status of the research is that the preclinical study is already over, and we are already finding that the research is promising, the results are promising, and hopefully the ICMR will take recognition of that and will give us the approval for the clinical trials, maybe hopefully in 2022 or maybe in early 2023. Now, the second project that we are funding is about the allogenic human adipose-derived mesenchymal stem cells derived pre-myogenic cells for DMD. And this is a pretty infant right now. It is in a very initial stage. The in vitro study is being conducted in Nizam Institute of Medical Science and ESIC Hospital in Hyderabad under the leadership of Dr. Madhu Mohan Rao. So those results are still awaited, but the initial results, we find that the ADMSCs can be differentiated into muscles. So still a long way to go there. The other research that we just recently inked our MOU was with the University of Kalyani in West Bengal, around 50 kilometers from Kolkata, where we are sequencing the human utrophin gene, and that's a CRISPR-Cas9 mediated utrophin upregulation by deleting the repressor elements in the 5' UTR. So this is utrophin is basically a homologue of the dystrophin and very much similar to dystrophin. So there have been research. Sorry.
I again request you to quickly wind up,
Okay.
please.
Yeah. So that's the last one, and we are also doing one research in hospital here at Sir H.N. Reliance Hospital, which is in collaboration with University of Portsmouth, US, where we are just trying to see whether the zidovirine, which is an antiviral drug, anti-HIV drug, can be repurposed in DMD. Can I have the next slide? So what are our expectations from the government? So I'll just go through it because we are running out of time. To provide health insurance unconditionally to the children and adolescents born with the genetic disorders. As we all know that the genetic disorders are not covered under insurance. So this is what we expect from the government, to have the health insurance for the genetic disorders. To direct the health insurance companies to cover at least palliative care expenses of the children and adolescents born with the rare genetic disorders, to provide respectable funding and infrastructure to diligent scientists and researchers within India, so that the drugs for rare genetic disorders can be developed indigenously and made available to the patients at affordable prices. To provide incentives to the private companies to develop drugs for rare orphan disease, because we have been communicating with many pharma companies in the industry, but they don't seem to be interested in promoting research for rare genetic disorders because the numbers are less. So here, some incentives can be provided by the government. So the pharma companies can also work in this direction, though we are funding the research, but that's something not at a very large scale. It's just the independent funding that we do to these 4 projects that we are currently ongoing. So a large funding is required, and that cannot be done without the support of the government. Word of thanks, we thank ORDI and its founder, namely Shri Prasannaji, to give us an opportunity to present our organization's work from its inception till now. We also thank our diligent doctors and researchers. And one of the doctors is here right now, Dr. Rashid Merchant, who's been a good friend of mine for the past 10 years. So Rashid Bhai, thanks a lot for guiding me. And last but not the least, we extend our sincere gratitude to all our fellow PhD leaders for standing together in each other's mutual interest, without whom ORDI is not complete. So wind up here because we are running out of time.
Thank you so much. That was a very, very impressive presentation, especially because you've taken up so much of research projects, and it's not very usual that parent organizations are able to generate support for research in the area. So with that, I thank both the speakers for taking us through their journeys. May I now request Prasanna ji to close the session with his remarks, and if he would like somebody to take over, especially if Dr. Merchant is still around, can we have a few words from him?
Yeah, probably I request Dr. Rashid, to say a few words to PAG, word of wisdom, and then maybe we can take a couple of questions.
Right.
Yeah. Dr. Rashid.
I am I am left dumbfounded to know what great work you people are doing, including Amrish Bhai. And frankly, I have learned more from Amrish Kapadia and from you on this disease than what I have known. I'm a general pediatrician who looked at a group of patients with DMD. We have some presentation. I have forwarded it to you, Prasanna, as well as to Amrish. We were hoping that we would be able to be part of the gene therapy and the CRISPR-Cas9 project along with my group of geneticists that I work with, that is Dr. Amisha and Dr. Snehal. But really, one of the things, Amrish Bhai, and one of the things that we noted in a very small series of about 40 patients of DMD I think I've shared the data with you.
Yeah, I saw that.
It was interesting that 4 out of the 40 patients who ultimately, at the age of 3 and 4, presented with difficulty in walking and toe walking, which was one of the first things that happened. So, to me now, any male toe walker, the first thing, of course, we look is to see if he's got a gastrocnemius hypertrophy of his calf muscles. But more than that, in the second year, first in the half and second and third year, even before they develop their muscle, their muscle disorder, their motor dysfunction, they seem to have, and a good percentage. I mean, 4 out of 40 is really 10%. Tend to have ADHD and behavior like autistic spectrum. So
Yeah.
we have now been telling all those organizations that are dealing with ASD and ADHD that any male child who has this, please look at his calf muscles.
Hello.
And see if you are able to pick them up early. I mean, the earlier you pick them up, the earlier you can start intervention. And I think there is a very strong need to do genetic testing for all our patients. So I don't know in your organization, I don't know in your organization, both of you, how many of the number of patients you'll have got, and how many have got all genetically charted, and where the mutations and where the problems have, because the gene therapy, as you know, is very targeted towards at a specific point. I really don't have anything more to say to this than to congratulate you people on the great work that you all are doing. Thank you.
Thank you, sir. We look forward your participation in every Sunday also, because every Sunday 2 new patient group leader would be sharing their experiences and their work. Kirtitaji, you can take any questions if there are anything.
Well, there are many questions in the chat box. Most of them have already been answered by Rahul ji, at least. I think there are a few questions. I think there are a lot of comments on the wonderful initiative that Amrish Ji and group have done in terms of promoting research. So that is very encouraging. I have a question for both speakers. Since both of you mentioned that your inspiration came from US organizations, and I think many of us have been working with international organizations and have taken help of their support to work in India. But my question to both of you is, can we understand from you whether you exactly copied what the US organizations did, or did you adapt the strategies and activities that were prescribed by the US organizations in a way so that they would be more culturally and socially suitable for India? So if you have any thoughts on that, both the speakers, I have a question, and then we have Samir ji who would like to ask a question. So any way that you made any changes?
Yes. As far as DMD is concerned, the protocol for steroids is like universal. That when a child is diagnosed with Duchenne, they should be put on steroids. The dosage is also well prescribed. But we found that that dosage was not appropriate for our children. So Dr. Vishwanathan in Chennai, the neurologist, he had taken the initiative where he did a dose escalation study, and he found that the US prescribed dose is something which is not appropriate for the Indian origin children. So he made modifications in that, and that is really nice to see that, you know, the revised dose is giving lesser side effects of steroids. So that is one change that had been made by Dr. Vishwanathan, that instead of 0.90 milligram per kg of deflazacort, he came up with a study which supported that 0.65 to 0.75 milligram is enough for the Indian kids to overweigh the risks versus benefit. So we have more benefits with the lesser dose compared to the US children. And we've been interacting a lot with the researchers outside India also. And in 2012, we had found one research group who had done lisinopril and losartan were tested in the mice. And we took it first. And in India, doctors started to prescribe this after a lot of awareness was spread about this particular two drugs. And we found that later on in 2018 or 2019, the US guidelines included these two drugs in their DMD care manual, which we were following in India since the research was done in the mice, and many patients, many doctors took up this drug aggressively. So there where we differed with the US organization. But later on, again, it was the same thing. In 2018, they also merged these two drugs in their care guidelines.
Thank you, Amrish ji, for that. And Rahul ji, would you like to say anything?
Yeah. From a clinical practices perspective, the Indian doctors adopt the US FDA guidelines and the research guidelines which are coming out of US and Europe quite easily. I don't think there are any modifications. Where I saw some differences in clinical practices are in India, we have a lot of alternative therapies. One of the things was this cannabidiol treatment, and that was affecting the efficacy of the medicines which are being normally prescribed. So there was some back and forth, but US catched up with the CBD oils, and now I think both of them are in sync. The differences I see are more in terms of the organization of the associations. One, our parents, our caregivers are a bit more reluctant to be coming out into the society and standing up for their rights.
Right.
So that is a major difference. And because of that, we have to spend a lot of time and effort in trying to counsel them, saying that it is in the best interest, it is your rights, changing their perspectives on how to go about it a little bit. And because we are not able to make the noise in India, I mean, we miss out on a lot of opportunities. We really don't know how things are going to work out unless we kind of raise our voice and say, this is what we want. So that's, I think, one of the major differences. And another difference is, like, I think people in US are much more generous as far as donations is concerned.
Correct. Right.
They
And
appreciate that it's a part of life. You make money and you give back money. So here it's a different philosophy.
That's the reason that the research in US and Europe is leading. I mean,
Yes.
You find it difficult here to raise funds. I mean, obviously you expect a lot from the government, but the ground realities are something different.
So I think at a very high level, the major differences I see.
That is really, Rashid ji, do you want to say something?
No, I just thought that the SMA group, the parents have been so much more aggressive. I saw Amrish Bhai and I know Rahul and Anand, and all of them have taken initiative. But the SMA parent group and their foundations really have made a dent. I mean, to be allowed, to get crowdfunding for that is so important. I think we still need to be much more aggressive. Just a word on caution. I'm happy, Amrish, you did bring out the steroid dose. I'm particularly concerned because for so many years now, I've been in practice for 50 years, and I've seen steroid causing so much harm. Particularly in our thalassemia and our this group of DMD patients who cannot walk, and who have got pressure. This avascular necrosis of the hip. I don't know in our group how many of our patients ultimately led. The avascular necrosis of the hip is a very devastating, very problematic thing. You just don't want to get your children's hips devastated because they need to have that hip replacements. So I don't know how many of our group what is the total number that we have, and how many have been sort of unsupervised use of steroids. So let's be very, very cautious in the use of steroids and have some interested pediatrician. You need the pediatrician, actually. You don't need specialists on board. You need the pediatrician who's interested to be monitoring this very carefully. Amrish Bhai.
Yeah, sir. Steroid is a gold standard for DMD for years. And as you are saying, yes, the risks are also more, the side effects are also overweighing the benefits. But if those side effects can be monitored and appropriate interventions can be taken, then I personally don't think that the steroids will be as harmful as they are given in an unmonitored and unregulated system. That is why I said that along with the pediatrician, neurologist, a regular checkup with the endocrinologist will also be very, very helpful to monitor the cortisol levels and the bone health, especially because we've seen that early intervention with zoldronic acid or those oral bisphosphonates, alendronate, can prolong the bone deformities and So that is what we have.
That's what I'm saying. Good monitoring from a well-informed pediatrician, or like each one of you should have a couple of pediatricians interested in helping out, and are well-informed, obviously well-informed about what's going on, and to monitor. I mean, you give steroids, yes, but you'll end up in osteoporosis and osteonecrosis of the hip. Is not funny. So just a point to make that, because
Because now we started with SRCC Hospital, Dr. Prashant Patil, and whatever patients that Dr. Anaita is seeing now, she is, forwarding them to Dr. Patil for as an endocrinologist to see the bone health and whether
Right. Right.
the simultaneously zolondronic can be started once a year.
Right.
So that is really helpful in preventing the fractures.
Right. Right.
And even, I mean, it's known you will be very much aware that steroids can can delay the scoliosis and even the cardiac fibrosis, which is the main
Right.
uh, etiology, which ultimately succumbs the child to death.
Yes. Yes. I mean, we have got some study on that also.
Right.
It's still ongoing on how steroids are also cardiac muscle beneficial.
Like we were testing troponin, as you know, sir, troponin
Right.
for the
Yeah.
cardiac. And I mean, sorry, we are just interacting among ourselves.
No, we are really over the time limit. So thank you very much for this very interesting discussion. But may I request Samir ji to ask the last question, because I think he's waiting to ask a question for.
Thank you,
for a
Kritida.
long time now.
Thank you. Thank you. I'll make it short. Amrish ji, my question to you is, how do you do the diagnosis? Is it a clinical diagnosis, or is it do you mandatorily require a genetic test also? And Rahul ji, you mentioned, one of the things that you mentioned was that in your group, you have not included clinicians, doctors in that group. Is there any particular reason why is it so?
Yeah, I can take that answer.
Yeah.
See, the thing is, like a lot of the TSC children, they face neuropsychiatric disorders, issues with schooling, issues with autism. And like I mentioned, we do try out a lot of alternate medicines also. So for example, in India, for seizures, the CBD oil was used by the parents first. The doctors didn't have a clue about it. So there are some things which the parents experiment on their own children, based on their global interactions and knowledge coming out from homeopathy, Ayurveda, and all that. So they want to keep that away from the clinicians, because it should not conflict with what is being prescribed by the clinicians. They might get upset. In fact, like there were a couple of cases where somebody got upset and said, no, you should not use CBD oil, go see another doctor types.
Looks
And
like we have.
was the CBD sourced in India? Or did you get it from US?
It's come from US
Okay.
because purity was not guaranteed in India.
Okay.
So I do have two more hands up, Murli ji and Sunil Kumar ji. May I just request you to quickly ask your questions and a quick answer? Otherwise, we will get your answers, your questions answered to on email or something. So if you want to, if there is a burning question, just quickly ask it, please.
Madam, my question is regarding the behavioral disorder. Is it related to the exon deletion in DMD boys? One question is behavioral disorder. And the second question is some children, most of the children suffer from gastro problems. Is any remedy available?
Rashid bhai, you would like to answer that?
No. You see, we all know that the Duchenne, gene, not only expresses itself in the muscle, but also expresses itself in the brain. So this is only an early manifestation of expression in the CNS, and where whether it is in the particular area in the CNS where it is causing a problem. Just to know that, from the group that I am working with now, with the neuro developmental group, we find that those children who have early onset, male children with early onset ADHD, ASD, at least please keep in mind the possibility of them also having, DMD. And therefore, look at their TA tightness, look at their muscle thickness, and do a CPK when you're building a blood level. You may get early interventions. I don't think. I think the group that are working with this group, and I might recommend here this group, which is called the New Horizon Developmental Center, NHCDC, are doing a good job, and they're really being able to, do something called an enable program, and it is helping those children at least to handle their autistic features and ADHD. Yes, so there are besides, of course, medications which are there for ADHD. So yes, I think this is a specialty area, and physicians or organizations dealing with this, I strongly suggest the group with Dr. Samir Dalwai's group is working on the New Horizon Developmental Center to be sort of referred to if one sees early onset of neurobehavioral disorders before the motor dysfunction takes place.
Thank you, Dr. Merchant, for that very, very useful information. So with that, maybe call it the end of the session today. If there are any more questions, can you please write to ORDI, and we will make sure that these questions are answered by the respective speakers today. We thank all of those who were able to participate today, and even those who had to leave a little early. So thank you all for being with us. And we look forward to your continued participation in this series, and we hope to hear from many more of our PAG leaders. We will keep you informed about the next date. Mostly it is next Sunday, but we will let you know. And anyone who wants to volunteer for next Sunday, please write to ORDI and tell us. There is no particular order. It is everyone should get a chance. So whoever tells us a preferred date, that would be wonderful. And we would like to hear from each one of us. Thank you all. Thank you all for being with us this Sunday morning, and looking forward to meeting you again. So goodbye and take care.
Thank you. Thank you, everyone.
Thank you, everybody. It was a pleasure.
Thank you.